Hello, everyone. Thank you for inviting me. I'm enthusiastic about giving this talk, and I hope someday that many of our meetings will be back to being in person. I will be discussing challenges in managing difficult cases in people with systemic lupus erythematosus, or SLE. I'm from London, Ontario, and these are my disclosures. I'm a professor of medicine at Western University and the department head in rheumatology. So I want you to think of how many patients with SLE do you follow? Because the more you follow, probably the more experience you have with difficult patients. So some of you are less than 10, and some of you might be up to more than 100, and some of you in between. When we think of lupus, the pathophysiology, we also think of genetics and environment and immune dysregulation. And these are just some of the areas where lupus has been investigated, and particularly looking at things we can change, like the environment, UV light, silica inhalation, some medication exposures, etc. And when you think of lupus, you want to think of who would do poorly. Is it people with positive anti-Rho antibodies, or SSA, with Smith, with anti-double-stranded DNA, RNP, both RNP and Smith, or anti-DNA and Rho? And if you're thinking about the answer, we'll see if you got it right, that the worst outcomes in those getting damage from SLE are RNP and Smith positive together. And not everyone thinks of that, but that's been true in many studies. So lupus is very heterogeneous. We have a patient with a malar rash. We have a Jacquard's arthropathy in the bottom panel, someone with livedo reticularis on their legs, and a patient whose hand, she actually has livedoid vasculitis. So it looks like livedo, but it's painful and can ulcerate, and that's actually someone with vasculitis from their lupus. I'm sure you're all aware that EULAR presented and published the 2019 recommendations for SLE. And when you think of them, you want to really look at all the things that this graph tells us. Make sure that your patients have a healthy lifestyle and have sun protection. There's treatment when lupus is mild, moderate, or severe. There's first-line therapy or refractory therapy. So our anchor drug is hydroxychloroquine. And sometimes there's bridging with corticosteroids, low dose and only bridging if mild, or an intramuscular injection of Depomedrol if the patient, or methylprednisolone, if the patient is just flaring with skin and joints and mild disease, up to and including severe, where first line or refractory. And you can see along the way there's drugs such as azathioprine or methotrexate. There's also belimumab, which I think will be extended further now that we have data and approval in the USA for belimumab in renal lupus. There's calcineurin drugs such as cyclosporin. And the FDA actually just approved voclosporin, where some of the lupus nephritis trials were actually performed in Pakistan and other places. There's mycophenolate mofetil, cyclophosphamide, and rituximab, and some have more data than others. And then looking at the other panel here, you're to try to target remission. So they say a SLEDAI SLE disease activity index of 0. Targeting a patient being off glucocorticoids, and if not, targeting low disease activity, and the lowest glucocorticoids or none, and still maintaining hydroxychloroquine, and possibly being on stable dose or low dose immune suppressive if they're in remission, or even high dose if they're tolerating it and need it. So these are very good guidelines. They're really our first international guidelines, but there are some criticisms that I have, this is my opinion, we need more data on treating to a target. The target isn't really agreed upon, and we don't need to worry about a SLEDI, in my opinion, if the residual SLEDI is serology. So someone has low complements, double-stranded DNA, positive, and Raynaud's phenomenon, their SLEDI would be greater than 4, but they might have no clinical disease activity. And Raynaud's is not something we would consider treatment with hydroxychloroquine or antimalarials. And then they're almost outdated now because we actually, fortunately, have more data in lupus that will probably change the order and expand some of our treatment options. In Canada, we have recommendations, but so far we only have recommendations on sort of the background of diagnosing and monitoring treatment and what to do with some of the comorbidities. So we actually have aspects that we talk about of cardiovascular risk, of corticosteroid problems such as avascular necrosis and or corticosteroid-induced osteoporosis, either prevention or treatment. We have some recommendations about pregnancy counseling, about infection screening and vaccination, on pap testing for cervical cancer, and the role of the caregiver. So I invite you to look at these, and more recommendations from Canada will be coming. So what about vitamin D supplementation? There are data of 50,000 units of vitamin D3 once a week that it can help fatigue. There are randomized controlled trials in children with lupus that it might help disease activity, but in adults with lupus, there's only case series. So that's something that might be inexpensive, that might help our patients. And obviously at this higher dose, vitamin D is acting differently than just a vitamin. It has some effects on immune regulation, and vitamin D might also help if someone has COVID in decreasing severity of COVID. So 33-year-old woman with active SLE failing hydroxychloroquine, what would you do next? So I want you to think of the answer and in your own mind choose. Would you give her mycophenolate mofetil? Would you give her methotrexate, azathioprine, rituximab, glucocorticoids, or a combination such as bridging glucocorticoids, and maybe you'd give methotrexate or azathioprine? So lots of right answers. So what do I do for SLE with arthritis? I think the treatment depends on the phenotype and also the severity. So if a patient is seropositive of rheumatoid arthritis features with positive anti-CCP, of which about 3% of lupus patients are, or positive rheumatoid factor, and if it's erosive, I'll probably treat her like she's an overlap of rheumatoid arthritis. However, like the picture you see of this patient of mine, this patient has Jacquard's arthropathy. It's non-erosive. You can see the swan neck deformity, the subluxations, the ulnar drift, and you can see the MCPs are still swollen. So in my opinion, if the patient has bad arthritis and you've used lots of your treatment algorithm, if they're non-erosive, Jacquard's arthropathy, I don't think TNF inhibitors work well. So I would use the TNF algorithm. And you're thinking, what is that? Well, we published with experts asking them what they would do in cases and of different disease manifestations. And you can see in the lupus algorithm, it was some would use bridging glucocorticoids, most would use hydroxychloroquine. Then if not, they'd add methotrexate. And then if that didn't help enough sufficiently, they would switch to either azathioprine or mycophenolate. And then they would consider using either rituximab or belimumab. So that is a lupus algorithm by at least experts that we published back 5 years ago. So a question that you can think of the answer: are recent lupus trials more likely to be positive, negative, or about equal amounts of positive and negative? And while you're thinking, what drugs may have benefit in lupus? Do you think TNF inhibitors work, baricitinib, ustekinumab, or do you think all of those might have a role? So you're thinking of these answers. And recently, there have been trials, many negative and some positive as well. And I'll talk about this, but unfortunately, ustekinumab now has a negative phase 3 trial, and they stopped their program for anifrolumab, which is an interesting drug. It had a negative first trial and a positive second trial. And if you reduce corticosteroids in patients with SLE on long time, low dose steroids who are stable, many will flare. So these are the ustekinumab, the phase 2 study that was positive. In the long-term extension here, I'm showing this. But then Janssen announced discontinuation of their phase 3 of the Lotus trial. This is looking at type 1 interferon and how it can help in lupus. And I invite you to look on nice reviews that have been done. And these are the data of the phase 2. There was not a dose response. The medium dose was better than the higher dose, and the medium dose was better than placebo. And whenever there's not a dose response, I'm always wondering if it's just good luck that a dose has helped, or bad luck that another dose isn't effective. And when they went into, so TULIP 1 trial was the primary outcome was not met, even though there were lots of interesting data that looked like the drug could be effective. So TULIP 1 didn't work. However, my lesson is that if a Lotus doesn't work and a TULIP doesn't work in lupus, that you shouldn't name lupus trials after flowers. However, to be serious, you can smell the roses, or in this case, the tulips. This drug coming back in phase 2, when they did change their primary endpoint, was noted to be positive. Now, the US FDA has to consider when the primary outcome changes, and when the first phase trial was negative with lots of positive data within it on second looks, will this be approved or not? And I don't really know, but these are the data that you can think about, because this might become a drug for lupus. Only people with high gamma interferon signature would be allowed to take this drug. That's where their signal was. So it would be accompanied by a complicated and or expensive blood test until that got standardized as well. However, we'll hear more about this over time. And really, the higher interferon gamma signature patients did the best. And who were they? They had a high signature to begin with, higher disease activity, the SLEDAI, younger patients. They were more serologically active, so complements being low, double-stranded DNA being high, and they had less comorbidities. So you can't generalize the entire data of positive results to all patients with this medication or this treatment pathway. Baricitinib is in phase 3, and interestingly, in phase 2, there were no adverse safety signals of clotting, so VTE, and no MACE or cardiovascular events that were imbalanced between active treatment, or the 2 doses, and the placebo. But of course, the treatment was small in numbers of people per group. So phase 3 is still underway, and you can see that SLEDAI improved best on 4 milligrams a day of baricitinib. And these were in active lupus, non-renal, so mostly skin and joints, some serositis, some cytopenias, things like that. Okay, another case, a 39-year-old woman with SLE of skin and joints and nephritis in past. Lupus nephritis is now good, and low-grade disease activity. Her SLEDAI is 4. She's on hydroxychloroquine and 50 milligrams a day of azathioprine and 7 milligrams a day of prednisone since her lupus nephritis. That's the steady state dose she finally got to. And she's been on prednisone for 13 years, and she's had early menopause and osteopenia. So of course you're worried about her bone health. So do you in your practice have problems weaning low-dose prednisone in patients with lupus? And you can think about the answer. I already hinted at it earlier in the talk. And this was a nice study that was presented at EULAR last year, looking at withdrawal of low dose corticosteroids. They've also now published it. And indeed, it was looking at time to flare. And if you look at the group that maintained their prednisone of 5 milligrams a day, their flare rate was very low. That's the red line. And the blue line, even early in the trial, looking over days to flare, even by 25 days, so 1 month or more, they started flaring more. Not everyone flared, but over 20% flared over this time frame of 1 year if you even lowered their background glucocorticoids by very low dose lowering of 1 milligram in a double-blind trial. So what about hydroxychloroquine or anchor drugs? So I want you in your mind to think, who is least likely to have eye toxicity from hydroxychloroquine or chloroquine? A 33-year-old woman with SLE since childhood, mild chronic renal failure, and she's been on hydroxychloroquine for a long time, 20 years. 66-year-old woman with RA on methotrexate, hydroxychloroquine, and sulfasalazine for 7 years. A lupus patient with just cutaneous, non-systemic lupus on chloroquine for 7 years, or a 55-year-old woman with chronic renal failure and Sjogren's on hydroxychloroquine, 300 milligrams a day for 7 years with a weight of 50 kilo. So you're probably thinking, because it's a lupus lecture, don't choose the lupus patients, and you might be right. And indeed, the answer is the RA patient. And these are data that we now have, we hope, in press. This is conditionally accepted. And our group looked at our patients in London, Ontario, where I practice, with SLE, but also taking hydroxychloroquine for other reasons, including non-systemic lupus, other connective tissue disease, and rheumatoid arthritis. And what we found, as have others, is that antimalarial toxicity to the eyes is very rare before 5 years. And our triangle was possible, whereas the dark circle and dark triangles are proven retinal toxicity. And you can see after 5 years, you start seeing toxicity. And some people can go out many years and still not have toxicity. So these are the number of patients and the duration exposed and the toxicity, proven or not. But if you're astute, you're looking that with SLE, there's an awful lot of circles on this graph compared to non-SLE, the triangles. And what we found was that SLE, independent of dose, weight, disease duration, duration of use of antimalarials, and daily weight and cumulative dose, SLE was an independent risk factor. And as I say, we have this, hopefully it will be published sometime this year. So a 27-year-old woman with lupus is contemplating pregnancy. So she asks you these things, and we'll talk about the answers. Can she continue with her antimalarial? Can she use her NSAIDs, as she has a lot of inflammatory arthritis and she doesn't cope very well without taking her NSAIDs every day? Can she continue her immune suppression? And then she also asked you, well, what are the risks to her? Will her lupus flare? Will she, not be around to mother her child for a long time? And what are the risks to her potential baby? So this was a nice systematic review presented at the ACR about a year and a bit ago, looking at the safety of antimalarials during pregnancy. And the bottom line is it is safe, that the overall effect seems to be more benefit than risk. And so many guidelines say, please continue the antimalarial during pregnancy, or else you have a higher chance of the mother flaring. If the mother flares, there could be a problem with her lupus activity. There would be more drug exposure potentially, and there could be a problem with small baby, small for dates and growth restriction and prematurity. So the risks to the mother include pregnancy-induced hypertension, the mother flaring if she doesn't have quiet disease around time of conception. The risk to the fetus is increased risk of miscarriage and stillbirths. And antiphospholipid antibodies certainly increases that risk, but miscarriages are also slightly higher in SLE, even if the mother isn't antiphospholipid antibody positive, but of course, even higher for poor pregnancy outcome if she's antiphospholipid positive, including small for dates, second trimester miscarriage, stillbirth, etc. And also overall neonatal lupus and congenital heart block. Unfortunately, at least in Canada, these are very uncommon. So some things to note is you want to know if the mom has quiet disease. So you'd probably look at double-stranded DNA and complement if you're doing pregnancy counseling, or at the time that she comes in pregnant, as not all pregnancies have planning beforehand. You want to know she's anti-Ro antibody positive, because the baby would have fetal ultrasounds of the heart around 18 weeks or 20 weeks up to around 26 weeks or so. Mothers can't have ACE inhibitors during pregnancy, as that can give renal problems for the baby, and MMF is contraindicated in pregnancy. So if someone's contemplating pregnancy, they're on MMF, you would try to switch them to azathioprine, which is okay during pregnancy. Corticosteroids, of course, are safe in pregnancy, and antimalarials are used in pregnancy, and we usually recommend aspirin to decrease pregnancy-induced hypertension for all moms with SLE. So moving on, true or false, if a patient has quiet lupus, can you stop mycophenolate mofetil without an increased risk of flaring over the next year? We already know that even changing slightly the low dose glucocorticoids can cause flare in 20% of patients over the next year. What about mycophenolate mofetil? To me, this was an extremely important study that was presented both at the ACR and prior to that at EULAR. And probably before seeing this presentation, I would have said, no, I think it's use it long-term, because if a mother needed, or sorry, if a woman needed mycophenolate mofetil other than in pregnancy, where I would stop it hopefully before pregnancy or at time of conception, or as soon as I know someone's pregnant, that's about the only time I would have stopped it, because it's if a person's on it long term, it's probably safe for them, and they probably had a good reason to use it. So this is a very, very good study, and it's an important study. So at EULAR and at ACR, it was presented, and I'm sure it'll be in press soon. And what they did was investigator-initiated, multi-site. They had people with SLE who had quiet disease, and they had to have quiet disease for quite a while prior. So for several months prior, and they were randomized to either withdraw mycophenolate mofetil or maintain it. And so it was an excellent non-inferiority study. So saying that probably over the next year, some people will flare, but will the flare rate be approximately equal with a confidence interval around the estimated flare rate if you withdraw compared to if you maintain mycophenolate mofetil? And the answer, in only 100 patients to do this study. So in Pakistan, I bet you there's many investigator initiated pragmatic studies you could do and answer many questions for us, because these aren't very expensive studies, especially if you design one that isn't blinded, so it's easier to have patients participate. However, in this study, there was no difference. So you can see the dotted red line. There were a few more flares, but the flare rate was not thought to be statistically different. So in other words, it was non-inferior, or in your mind, you would think it was about equal. You could take home your message that there's a small price to pay if you withdraw mycophenolate, and someone who's stable with quiet lupus, inactive lupus for a long time, a small price to pay of a small flare rate over and above if you didn't withdraw. So the difference at the end of that study of 60 weeks between the blue maintaining or the red withdrawal. And that has changed my practice. So now if patients say, I really don't want to take as many meds anymore, can I decrease something? When they ask you that, a clinical pearl, they've probably already decreased something or in fact stopped it. But now I'm certainly willing to, I would often lower a mycophenolate mofetil, but usually not stop my very last dose. I keep them at, say, 500 milligrams, or if you used my Fortic, 360 milligrams a day. But now this might indeed change my practice, that I might finally fully withdraw it. So our pearl is SLE patients, but in remission, not smoldering disease, but in remission for a long time. So a time frame on it can stop their MMF, but follow them closely. What about new drugs? So who would have thought that belimumab and voclosporin would be approved by the FDA for lupus nephritis? Only a couple weeks apart was the approval, just hot off the press. So belimumab, certainly we know it's safe in SLE. This was a large mandated study from the FDA of active lupus patients who were randomized to belimumab, in this case intravenously. It is also available subcutaneously, or placebo. And what they found is that actually, as a biological, belimumab had less serious infections and no other differences other than a few infusion reactions that were, none of them were very serious at all, and the rate was very low. Why would there be less serious infections on a biological, you ask? It's because the patients were able to lower some of their background corticosteroid dose or even get off corticosteroids, and therefore less serious infections. So huge safety was found on belimumab, presented at both ACR and EULAR over the last year. And what about lupus nephritis? So hydroxychloroquine use may improve the response of mycophenolate mofetil and lupus nephritis. So our nephrology colleagues often don't initiate hydroxychloroquine, but this is a nice old study from 2006 in lupus showing that it could enhance benefit. You might think that either it enhances mycophenolate mofetil or that 2 drugs for lupus nephritis are better than 1. 2 drugs for lupus nephritis are better than 1. Hold that thought, because it's true. So looking at hydroxychloroquine and lupus nephritis, should we be doing drug levels? Well, we don't have the availability. I'm not sure if any of your academic centers do, but if hydroxychloroquine had a sufficient level, and in this case, it was greater than 600 by this assay, there was less flaring of lupus nephritis. Now, you could say, well, maybe people who had a good drug level actually took their drugs, and maybe they not only took their hydroxychloroquine, they took their background maintenance therapy, such as mycophenolate mofetil. So there are lots of emerging therapies for lupus nephritis. And in this scheme that I got from the internet, and this is the reference here, I added the calcinuric drugs because they hadn't added them in. And because tacrolimus has data added to mycophenolate mofetil and on its own in lupus nephritis. Cyclosporin has some data, and voclosporin has just been approved as an adjunct to mycophenolate mofetil in lupus nephritis. So what do you think is better for lupus nephritis? if we're using one drug in addition to corticosteroids, so one immunosuppressive, mycophenolate mofetil, tacrolimus, or you think they're equal. I would have chosen mycophenolate mofetil, and I would have been wrong. They're equal. So this was a nice oral presentation at EULAR showing that a randomized controlled trial that's actually very old now showed that there was equal benefit. And I'm sorry, my color of tacrolimus isn't blue. It's supposed to be this green, but that green tacrolimus or mycophenolate had complete remission, partial remission, and looking at the various classes of lupus nephritis as well, that they were equal. And in fact, what was now presented was the long-term follow-up of these patients. So over the long term, over 10 years, you can see as well, now the color is right, tacrolimus is blue, mycophenolate orange, that they were equal on partial remission, equal in the long term on those having reduced GFR or renal, end-stage renal disease and things like that. So they were equal. But the buzz these days is that lupus nephritis should have overall less glucocorticoids and more combination therapy with immune suppressives, such as mycophenolate mofetil plus tacrolimus was better. 2 drugs were better than IV cyclophosphamide, all given the same background glucocorticoids. And there was half of the combination therapy obtained complete remission, only a quarter with cyclophosphamide, and 84%, or think really more than 3/4, only 15% or 16% did not have a response on MMF plus tacrolimus, whereas 1/3 did not have a response on cyclophosphamide. And these results were from Asia, and the generalizability of the results is uncertain for other ethnicities, such as yours or ours. And it's difficult to say, but very interesting. And then this is looking at voclosporin, and you could see voclosporin at either dose was faster at getting a complete remission than mycophenolate alone. So this was added to mycophenolate. However, there were more deaths that seemed to be from infection, so immune suppression deaths, and the highest voclosporin group. So will you consider using this drug in the future if you have it? Probably. What dose will you use? I think it depends on more safety data that will come out over time. But this is a real accomplishment to have 2 lupus nephritis drugs just approved by FDA. That's never happened before. So the other drug approved was belimumab. So belimumab, I showed you how safe it was in the long term, even less infections than placebo added to background active SLE care of other immune suppressants. This is belimumab added to background therapy, most of which was mycophenolate, some was cyclophosphamide. And looking, you can see that belimumab has complete renal response, 30% compared to only about 20% in the group that only had the background usual care. A partial renal response, which was still a strict definition, 43% compared to only 32% in placebo, or if you want to round off, it was closer, getting closer to 45% versus 1/3. It was a way to round off and look at it. And very safe drug in this trial as well. And this has led to an accelerated approval, which is very for this indication. Whereas before the drug had insights that it could help lupus nephritis, the trials, you could have lupus nephritis, but that couldn't be the reason you got into the prior trials. It was non-renal active lupus that allowed you into the trials. So now this was a renal trial that extended their label, which is very exciting. There's one other drug to think of in combination. So we're all familiar with rituximab, and despite negative randomized controlled trials, it has come up in our EULAR guidelines. So this other drug here called, I'm not even sure if I say it right, but the last drug on the slide that looks to me like humanized rituximab that has another little side chain. This I'll say it wrong, but obinutuzumab has been already reported in lupus nephritis as an add-on to have positive data in lupus nephritis, even though rituximab, as you recall, had negative data. And so this has been presented, the overall results have been presented at EULAR, and these are the results that were actually presented as exploratory and secondary outcomes at the ACR. So complete renal response was positive, and this is a revised definition where mycophenolate mofetil added to this CD20 depleter was better than mycophenolate mofetil alone. And the data are uniformly positive, which is very, very exciting for the primary outcomes. So, and the data were more impressive at year 2 than year 1 for that CD20 depleter. So lupus nephritis, what are the trends? Using less corticosteroids, more rapid tapering now, using solumedrol, but then starting at a lower dose and tapering more quickly. The trend is mycophenolate trumps or is used more so than cyclophosphamide, and the trends are certainly combination therapy. So MMF plus tacrolimus, MMF plus CNI, so cyclosporin or voclosporin. And also, I think we need more therapies because there are still at least 3% of our patients with end-stage renal failure, even in lupus clinics that publish all over the world, and 10% having renal insufficiency. And also over time, that 10% with renal insufficiency might be higher numbers over time as people are living longer. So very briefly, JAK inhibitors looking for cutaneous lupus features. No randomized controlled trial data yet of this JAK, but showing that JAK inhibitors might help in cutaneous lupus. Another study here thinking of a young woman with severe alopecia, but non-scarring, no discoid lesions. She asked you, is there anything that can help with my hair thinning? And you might say not really, or maybe drugs like topical minoxidil or Rogaine, but when you stop using it, it stops working. And like everything we do, it doesn't work on everyone. Or maybe you'll say yes. So this is looking at that JAK inhibitor, the Ruxo, looking that in autoimmune alopecia areata, it can be helpful. There's other JAK studies looking in alopecia areata with tofacitinib. These are case series, not randomized controlled trials. And also in baricitinib for alopecia and including universalis. So JAK inhibitors might be playing a role in lupus once we have the phase 3 baricitinib data, and lots more, I think, on JAK inhibitors and other classes of drugs to come. So now we can look at a diagram again, and we have so many pathways to look at modulating lupus and more optimism now. So interferon gamma pathway, maybe that drug will be approved. Ustekinumab has now stopped, but look, clinical trials, but look at all the potential pathways. So a lot of excitement now that we have positive trials. So in conclusion, B-cell manipulation seems to help SLE. So maybe the guidelines of rituximab do make a lot of sense despite negative trials, now that we have a B-cell depleter that's positive. Co-stimulatory molecules don't seem to be effective, so I didn't show you the data. Type 1 interferon inhibition, the benefits are unknown, but look overall like the data are positive, but they might have problems because their endpoints have changed. JAK inhibition may be effective, and unfortunately, ustekinumab, the IL-12/23 pathway, is probably not going to be pursued by any other trials now that Janssen stopped their trials. So with that, I hope you're going to have an excellent meeting. I'm so glad I could participate, and I tried to be interactive with at least questions as I went, because this will be airing in the wee hours of the morning during your meeting. So with that, I thank you very much.